Hello again. My name is Celeste. I'm the nurse practitioner, or one of the nurse practitioners for the substance use programs at Park Place Behavioral, located here in Osceola County.
Hello. My name is April. I am a nurse practitioner and I work with the David Lawrence Center. I'm one of the nurse practitioners that works in the medication-assisted treatment, predominantly in the detox unit as well as our residential program, but I also work outpatient.
All right, awesome. Thank you. So we're going to be discussing policy and ethical considerations. And so does anybody have any pressing questions? If not, I will jump to my list of questions. All right, I'm just going to get us jump started here a little bit. So in recent years, what best practices or innovative models of care have shown the most promise for improving outcomes in our elderly population? I have thoughts. So for one, I would say that we have to be realistic about that answer and say that there is a significant paucity of research in this area. And so we don't have a whole lot compared to other populations of really, really good knowledge about the outcomes and what works best with this population. Compared to others. So one of the things, but I see that changing. So one of the first things I would say is that I think we're actually I'm seeing now that we're beginning to see more research into that area and specifically looking at outcomes. So that's the first thing is we haven't really been looking at them. Certainly not, if you go, do your PubMed search or whatever, you'll find some research on an outpatient basis, but that's just about it. So the first thing is I think that we're actually beginning to see this as an important topic and doing some research and looking at the outcomes. I'll start there. I don't want to hog it.
I just like to, really touch on that and agree that if we don't know where we've been, we don't know where we're going. So without the research base, we don't really have a good idea of what's going to work, what will work. So research is definitely one of the points that we need to demand from here on out.
Great.
And from a personal, clinical experience, I can't really say per se that it's just for the geriatric population, but I would say that it will work for literally anyone. If you just show them that you truly care about them and try to meet them where they're at. So we have some geriatric patients who have come in on ridiculous amount of pain medication or benzos that they're trying to get off of. So I explain to them that even if it's prescribed, that doesn't necessarily mean that you need to take that much. But again, that's beyond my scope of practice when it comes to primary care. So I tell them that this is what we're going to do. And if they are willing to participate in the treatment plan, or if they have any recommendations on what their comfort level is, then I work with them on that aspect. And then we just continue to build that relationship, and eventually they'll be more forthcoming, more participative in their own treatment, and then we can start making a difference.
And if I can just follow up on talking about pain, one of the things that especially I think clinicians that are therapists, that are not medical folks, really I find makes a significant difference is just having some basic education on the fact that all pain is real, and our culture, and especially even clinicians sometimes that aren't medically trained will kind of talk about the pain. Let's help you figure out what's real and what's not in your pain. And when it comes to building that, because again, everybody's talking about in our different ways, building that relationship, but recognizing and coming from a place that all pain is real and all pain's in your head, right? But from just because you mentioned that, I wanted to say that I've seen a significant difference in people who, when clinicians and family members take that approach, as opposed to let's figure out what's real and what's not. It's a good point. We talk about pain all the time in the medical field. In the ER, we want to know what your pain scale is. 1 to what? 1 to 10. It doesn't go to 11 like a lot of my patients have 11. So, but 1 to 10, we talk about pain scale, have to treat pain. And I think probably the discussion isn't, I'm going to get rid of all your pain. It should be, how can I manage it? How can I bring it down from a 10 to a 7? Right? Can you manage a 7? Maybe we go to a 6 or something like that. Those are probably the discussions we need to have. At least probably need to change the mindset of most Americans in regards to that too. So, so how can stigma and ageism be addressed to encourage seniors to seek help for substance use without fear of judgment? Heavy.
Go ahead.
So, can't make it okay? Because I just want, that's such a critical question. It's critical. Stigma kills people. It is so huge, but we throw it around. So stigma is this, when we have a negative judgment about a person or a group of persons, that kills them. And again, I think one of the things that I've is important to me as a clinician and has been very important has been really increasing my own understanding about how generational cohorts deal with stigma in different ways. And so as a clinician, and if there are physicians or clinicians, or I think all of us, I think one of the things that we can do to help overcome stigma is recognize that different generational cohorts, like, you know, the baby boomers experience stigma in a very, very, very different way than that great generation, that World War II generation, and they experience very different from young people. So I think one of the things that we can do is educate ourselves as much as possible on how generational cohorts tend to experience stigma. We have to remind ourselves again and again and again that things are not a thing. So stigma is not one single thing. It is this definition and this thing that kills people, but it is manifested differently in different generational cohorts. So we talked just a little while ago about recognizing that, maybe that great generation, that World War II generation is going to, if using words like alcoholic or addict, that is going to trigger an internal stigma that will create a barrier that it might not with as much with the baby boomer generation, but something else will. So I think part of it is recognizing how generational cohorts respond differently to stigma. Yeah, words matters. Any other comment? No pressure.
I'm big on education. Education for our clients. A lot of them have, if we talk about stigma can come from society, it can come from self. I've met a lot of folks that don't want XYZ because of something that, is pre-recorded in their head that they may have heard. By educating them and giving them a full array of options, none of which they have to take, they can, be better open to making the best decision. I mean, we talk a lot about informed consent. Is it informed consent if we don't give them all of the options that are available and the benefits and the risks, and doing it in a, destigmatizing way, letting them know that, this does not mean this, and, these are available regardless of, if you want to call yourself an addict or,
that's right.
These are available, and we do know they save lives, and not pushing an agenda.
And that is very true, because I've had patients who are hesitant to go with my recommendations based on my age. So I tell them that it's perfectly fine. This is evidence-based best practice, but it is completely up to you. But what I want them to feel is that they are empowered to make their own decisions. And I tell them that regardless of who you have in your life, whoever is talking down on you, however they're making you feel, this is your recovery, nobody else's. If you're doing it for somebody else, then most of the time it doesn't really work out how we want it to be. But if you're doing this for yourself, you have to be your best advocate, and you tell me this is going to be a team effort. I can tell you what my recommendations are. You tell me what you feel comfortable doing, and we can start there. And then from then, we continue the conversation, and hopefully we can get you to the place where you want to be.
And the idea is ageism, because that can go right both ways, okay? But there's a long time ago, 20 some odd years ago, my job, I was the therapist who did Marchman Act assessments for this specific court. And this is, I would do clinical assessments, and based on those assessments, people could be ordered to treatment, which we could talk about the ethics of that, by the way. That's a whole nother thing, because I struggle with that one. But the judge, there was a judge in this room, and I had my little desk, and there was a bailiff. It was a courtroom. And this is a long time ago, but I remember that there was an adult who had brought his father to Marchman Act Court. The guy was like 70-something years old, and the adult had said, my dad's drinking is out of control. He's killing himself. He's lost his relationship with his grandkids. I'm asking the court to order my dad to treatment. Alcoholism has got him, and he can't make decisions for himself. And there was a break in the case. And the judge was a person who was brilliant and who really cared about everybody. I don't know if you've seen mental health court judges, but they do that on purpose. This judge loved the people who came before her. She believed in integrity. I mean, she was great, and she was smart. But there was a break in the case, and she said to the bailiff, God, I'm going to follow the law, but this one's crazy. I don't know why this guy's bringing his dad here. Let the old man have his booze. He's earned it. The idea that she had was the most ageist idea, that there is a time and a place where we come to an age where our ability to fully connect to life, where it stops mattering as much. And I think that is an ageist idea that's actually ingrained in our culture. And I use those words like throwaway people, and because, by the way, addicts, people with addiction are also throwaway people. But the reality is, what I find is many, many, many of us, many professionals, many really caring people, many have this Western idea that at some point your ability to fully engage life isn't really all that important. And I think that for me is the root of what we have to be intentional about, inspecting our own thoughts and our own beliefs, and then helping those around us do that as well, because that is the fundamental ageist idea, I think, that really ends up. So we've got 5 million older adults who need treatment, and about 2 or 3% are getting that help. So I think that, for me, I have to say that when we talk about ageism, that again, this is not bad people. This isn't dumb. I think it is an idea that a lot of us have ingrained in us without even realizing it. And so I think it starts with self-examination and then accountability together. And then we move to, changing the world.
Well said. Especially like the bumper sticker, stigma kills people, right? We just get stigma kills. There's no doubt about that. Changing that will be very important. Okay, go.
Another question. How do stigma and age-related stereotypes influence the way that substance use among older adults is perceived and treated, and what ethical steps can to ensure that the older individuals receive the compassionate and evidence-based care?
I mean, in my personal opinion, I think the best way to approach it is saying that, there is no difference between this person and that person. It's just when they come to us for help. So it doesn't matter if they're young or old. They all come with their, same set of demons, well derived from different things. If we approach it as treating every individual, regardless of age or situation or, socioeconomic difference, and just showing up, meeting them where they're at, and assessing, who they are, what their needs are, to the best of our ability. I think that's a good start.
Well said. It's funny, the one of the biggest problems is that we normalize it and say it doesn't matter. We need to recognize that it's not, the stigma is not just the shaming, you're all, the shame and the negative chat. It just as dangerous is when we normalize and say it doesn't matter. Either one will leave people sick.
So a couple of things about stigma. One, language really matters. And so when we're talking about substance use disorder, I still hear a lot of professionals and people call it substance abuse, which is very stigmatizing. And so I encourage everybody in the room to think about that terminology before they use it. And then I have my own stigma story. So when I was 20 years old, I knew I was spiraling out of control with my substance use. And yet I was a well-respected respiratory therapist in a teaching hospital. And so I was too ashamed, too self-stigmatized to ask for help. And I used for another 9 years, which derailed my career. It derailed my dream to become a medical doctor. And all really because, I relate it back to stigma. And as the work that I do today involves a lot of education and training. And I'm privileged to be able to train first responders because we have a first responder program. But I train corrections and the sheriff's department and other LEO about substance use disorder recovery. And a big part of that is about stigma. And I tell my story throughout the training. And it's really impactful. And we've been able to reach a lot and make a difference. And we talk about self-care for first responders through that training. And so I just really, stigma really does kill. And so often, I say I got into recovery the day before my obituary because I was on death's door. And still, really, if it wasn't for a friend and a colleague who worked at the hospital, I would probably have died. But she took the chance she was a peer before there were a peer movement. And she reached out her hand to me and dragged me to a meeting. And I've been in recovery pretty much ever since, once I put the other drugs down. So I just really wanted to share that and how important it is that our language matters. Thanks.
Thank you. And that point of, yes. Your point that a friend grabbed you. 20 some odd years ago when I was sitting in that courtroom and that judge said, let the old man have the booze, he's earned it, I bought it. I thought, yeah, that makes sense. And it was you. It was my peers. It was mentors. It was, other therapists who challenged that and who helped me. And so I can't overestimate or overspeak the importance of us being willing as professionals to respectfully speak to each other, to challenge each other, and to say, that language, that actually, that might not work. That what you're thinking, can I give you perhaps another idea or another perspective? So the power of us in this room to change our field, because I've been able to tell that story 1,000 times to 10,000 people, right? And it's powerful. So I thank you for reminding that it is friends and it is colleagues, and we cannot underestimate the importance of being willing to challenge each other so that we can grow.
Well, I appreciate that. As a recovering stigmatizer myself, I had the same kind of problem in the ER. I mean, I was very judgmental, but to your point, people can change. It is kind of up to us to kind of explain to them that words do matter, right? And I give a lecture every month at a residential community. and I talk to them about, I go around, I teach doctors and I teach healthcare workers and EMS all about addiction. And I try to explain to them, about stigma. And I said, but there's one group that is by far the hardest because they're the most stigmatizing group. And I said, it's all you guys here at this residential community. The people that are in the recovery themselves are stigmatizing each other as well. And so I have that discussion with them, and because I'll talk about medications. I'll tell you right now, there's a lot of, oh, that's the devil, all this kind of stuff is the worst thing in the world. But by the time the lecture's done, we've talked about everybody has a different road, right? It doesn't all have to be some road. The road that we're trying to get to, the goal we're trying to get to is where we're trying to go, whatever that matters. And so trying to break down that stigma, changing the words that we talk about, it really do make a difference. So, but people can change. People can change. So, Total tangent. I like it. Okay.
And I have something to add to that too. So this is another thing that I have been working with my staff as well as my patients. I always tell them that addiction does not discriminate. Any one of us is vulnerable. It can hit us at any point in our life, at any age. So we should all be thankful that we're not currently battling addiction, but that doesn't make the person any less. So they are in the worst of circumstances, and it is hard enough for them to come voluntarily to seek treatment. So we should, at the very least, give them that respect and treat them as a person, because again, at any point in your life, you could be on the other side of the desk and you could be experiencing the same thing. So having that mindset is very helpful, and it has, I would say, has helped us better ourselves and helped our patients to realize that they are worth saving, they are worth the help, and that they are not a burden to us.
In that same respect, if I can just step in, a lot of times we get folks in it's, what did you do? What happened? Tell me about the relapse. I like to approach it with, what happened to you? What, not what did you do? What happened to you that, shifted, made, something unsettled where you found this substance versus, seeking help in other ways. So less of, the approach that it's a moral failing, and more that things happen and we can really define, what happens contributing to this versus, what they did, and making it punitive and a place where they don't want to come back and get help.
Well said. Any questions out there? All right. Are current healthcare policies and Medicare coverage sufficient to address the needs of seniors with opioid and stimulant use disorders? And if not, no. If not,
Absolutely not.
what policy changes are most urgently needed to increase funding and support for geriatric-specific SUD services?
So they do not pay for a residential level of care outside of a hospital. There is so much evidence relative to the efficacy of residential treatment, especially for ASAM. Yeah, I know that our ASAM levels are, nothing is, it's not like the Bible, but man, they're pretty darn good. And they've got their great guidelines. And we know that a lot of folks out there, in fact, older adults are more likely to have with a substance use disorder, especially addiction. I'll use those terms in severe substance use disorder, and addiction. I'll use sometimes interchangeably, but we know that these folks are more likely to have at least 2 other chronic medical conditions. They need more medical care. Detox takes longer. It is harder. They have, there's a whole list of why residential treatment is wildly necessary for this population. And I personally have seen it for decades. And Medicaid does not cover it. Now, even if they started tomorrow, there is actually one program in the United States. There's a program in California but it's a hospital-based program specifically for older adults. So there's one program that will accept that healthcare in the country. There are about 6 programs in the country that actually have residential level of care that truly treats older adults in a competent way. So one thing is we need the changes. We need to pay for residential level of care, and 2, we need to establish more. I would love more competition, please.
And we see that in our program too. We have a lot of patients who come in with just Medicare Advantage plans. And unfortunately, those are not going to be eligible for residential treatment. We did have grant funding for a while that allowed us to take patients whose insurance does not cover residential treatment under that grant funding, but we've had some recent changes, so that number has been cut drastically, and it has very much impacted our patient population, and we're hoping within the next legislative year that we're going to get more funding. That way we can help more people, and they are really the ones who are in need of help, because for a lot of them, they've already burned bridges with their families. They're living out on the streets, and they're at that age where they should not be living out on that street with all their comorbidities. They're not getting the medications that they need. And it's sad. It is a very sad reality that we're living with right now, but we try our best to help those that we can, and hopefully we can get the legislators to be on the same page.
Comments, questions? Oh, back here.
Very generic comment, once again preaching to the choir, but I preface it with that. One of the biggest things is just the need for basic case management. I mean, as counselors, we do it to the best of our ability, but as was mentioned earlier, it's like the car repair shop analogy, right? You got, I have, as an executive director, I do other things with my prevention coalition, but for my counseling portion that I do, I have half or less than a half caseload with 21 clients. Most of the counselors there have 50 or 60 clients, right? And you just spend quality 30 minutes with each one of them at a medication-assisted treatment clinic and go through all. And then if it's a treatment plan day or, update biopsychosocial day, forget it, right? So just people are not aware of, when you start talking Medicare, Medicaid, people, their eyes can glaze over unless they've been through the system, which at this age, a lot of people have. But it's still challenging when it comes to what's acceptable, when it comes to maybe this is the first time in their life they're looking for treatment for a substance use disorder. They probably know how to navigate all the other stuff, but Medicare Advantage plans and, who takes what, and then can I have them on full maintenance if they're Medicare? Well, right now, no. Medicaid, yes, we can now, but commercial insurance, no. They may not be able to be a phase 27 at a methadone clinic. They may need to, they have to be private pay, or it is hard just to manage that, and then plus what other resources they may need to support their recovery. So just in general, if we had better case management just for that alone outside of the treatment piece, I think it would help navigate.
Yeah. And I think the key also that we keep coming back to research, and I'm very fortunate. We have a foundation, and we've been able to develop a research arm, and now we have our federally registered IRB internally, and so we'll begin, 5 years from now, hopefully you guys can hold me accountable, right? So I should have a lot more data, but we've got to design the data to really not just to advance the scientific and medical community, but also to prove to insurance companies that it's cheaper to treat older adults addiction than it is to be, because we'll do, those of us that are working in this, we're like, it is going to cost, they're going to be in the ER, and they're going to be in addiction that is untreated is so much more expensive, but we've got to prove it. So I think research, and that's also where I think all of us, even in little ways, can, find in your community, are there people, is research happening in your community? Can you join? Because the more numbers that we have The more we're going to be able to, kind of yell at the insurance companies and say, hey, dummies, you're going to, as well as our legislatures who are, managing Medicare and Medicaid, and say, this is actually going to save you money. Treating addiction, I believe, and anybody who, I can't give you the numbers yet, but treating addiction, am absolutely positive, is a lot less expensive than dealing with all of the consequences of untreated substance use disorders.
So I can give you some numbers from another lecture that we've given before. So it costs like $35,000 a year to handle patients in the healthcare system and Department of Corrections all the way down, and it costs about $13,000 to treat the addiction. So it's kind of like a third, right? A third of the cost. When you look at patients that are in corrections, right, and you're trying to detox all these folks because we don't want to give them medication at all to help them. Think about first of all, unethically. I think that's just from an ethical standpoint, this person's miserable. Well, think about all the cost it's going to be for if this person actually does get sick and have to leave. Now you're taking guards out. That's going to cost thousands and thousands of dollars. The guards that are taking care of the patients is sick. It's miserable for the patient. It's miserable for the guards as well. Had you just given them a medication like buprenorphine, suddenly you're like, okay, like the person's not sick anymore. You're not having to send them to the hospital. We're saving money like crazy. Over the last 10 years, I think it's cost the healthcare system and loss of jobs, things like that. Like there's one report that talks about $750 billion of lost revenue from that. Where we've only taken, of that $750 billion, only 5% of it went towards treatment. Yeah. Right? So there's a huge disparity from that standpoint. Right. Any other questions, comments?
So I really appreciate how the cost analysis is the focus. And I feel like that's something that's been shared a number of times, is that, hey, we're actually spending more for homelessness, incarceration, emergency room visits, etc. What is the general advocacy approach that maybe we all could share in a unified message to hammer home that in our own individual areas? Because I really respect, with the way things are changing, that we hope for a better new legislative period for funding. But in the event that doesn't come to be, and we continue to double down on policies and procedures, especially here in Florida, that are quite antiquated, what could we do differently theoretically as a community?
If I get, here's the bottom line. We live in a country where the rules get made by people that we vote for. And I think that advocacy, our own advocacy, person to person, is, people do change and minds do change. And I think we can have that hope, and we can do all the, and we have to do the yelling, and we have to do the letter writing, and we have to do but I think in that, because I feel the frustration in the question. I'm also offended. No, just kidding. Sorry. Okay, never mind. Those that were, if you know, you know. But there is, I think, in all of us, what do we do? And for me, when I think of that question, if nothing changes, if things just, today when I leave here, I go to the airport to fly somewhere else, and if I have an opportunity to sit down with someone and who's talking about those old, addicts that just need to be, shipped off, if I can talk to that one person and I can just advocate a little bit, if I can teach my family, my kids, I have, my oldest kid is 28 and my youngest is 9. And that's right. Thank you. And all of them understand what addiction is. And all of them can talk about the neurobiology of addiction and the addiction as a disease. For me, I think it is making it our life's work to educate and advocate person to person to person. Yes, we need the big things. We need the letters. We need the marches. We need the phone calls. But also, how am I living this out? How am I living out advocacy person to person in my daily life?
And I'm going to add to that because we had to recently deal with this as well. So yes, we can preach to the choir and nothing ever changes. So we as an organization, we have to be flexible and we have to be creative on how we can, I don't want to say play their game, but how can we find other avenues to tap into other resources that we can use. So like in our program right now, the funding had been cut significantly, so we had to look into other sources of funding. So we have all of these levels of care, but hey, we can participate in the core program and establish a living room model. That way we can help people, but we can also tap into this funding source and it can hopefully expand to even more services. So those are just some of the things that we actively work on with our administration. And we're very, very fortunate that our administration, they have our back and they're very transparent with us. So let us know how much we have to work with. That way we can figure out a way. And then us as frontline clinicians, we also empower the staff and let them know, hey, this is where we're at. This is what changes are coming, but we're going to make it work. And eventually we're just having a bit of a rough patch, but this is eventually, hopefully, going to work out because they're going to see that we're going to help people. So hopefully that'll inspire them to give us more funding. So it's really just a balancing game at this point, which is, again, unfortunate, but something that we have to do because we are not on the losing end. It's our patients and it's their lives that we're dealing with. So we have to do everything that we absolutely can and be their best advocate if they're not able to advocate for themselves.
Dr. Diamond, I love how you said this has to be our life's work. It does. I mean, and how much does that cost for you to go talk to one person as you go home? How much funding do we need from the federal government to do that? None, right? Every one of us can talk to our family, our friends all day long, continue to educate. Education's a big deal. Yes, education costs money. I understand that. But as you start educating more people and they start to understand this more, guess what? The harm starts to go away a little bit better. Maybe we're making some strides in regards to that. Maybe doctors aren't prescribing as many medications as they used to before. Maybe we're talking to our legislators to make good choices, to vote for the right things for patients. We need to advocate for all that. So all of us have a voice here. I love coming to these conferences. I mean, I've been doing this a long time. I learn every time. I'm like so excited about the whole mechanic story. I'm taking that home with me if I can, if that's okay. But, every time I come here, I learn from all of you. Some of you have had lived experiences. Some of you have not. I just learned from everybody from that standpoint. That makes me a better clinician. It makes me a better educator as well when I go talk to other people. So thank you for everybody's input. I don't know how much time we have left, so. Okay, 4 minutes. Any last comments? Any other questions at all? I have a last question if I need. Although it's kind of like at the end, right? My microphone's going out again. How can partnerships between healthcare systems, aging services, and community organizations be strengthened to provide a more holistic approach?
Networking. So we are a small facility, but we have grown so much, and that is by word of mouth from our patients, by us actively networking and partnering with local hospitals and other organizations so that they will know about what services we offer, what services we can offer to their clients, and then how they can also contribute to better the community. So we have grown significantly through that, but that's just one of the things that we can do as an organization.
Great answer. Anybody else? Thank you for your bravery.
So I had an agency policy question. Recently, I've seen an uptick in policies where if an individual on MAR medications is testing positive for alcohol or benzos, they're essentially told that they have to seek a higher level of care, and they're given a short-term script to move somewhere else. How do you guys feel about that approach to treatment?
For me, that is ludicrous. I would highly recommend for that person to seek treatment elsewhere, because it's not black and white. You have to pick and choose your fight. So let's say the main issue is opiate use. If we can get them off fentanyl, then hey, he lives another day, and we can fight for one more day. If they come back with a positive UDS, then there has to be some accountability. Yes, I would insist on that, but that does not mean that they're going to be kicked out of the program. I may tell them that, hey, we need to see you a little bit more frequently. Instead of every 4 weeks, we'll do every 2. I need to at least see that you're trying to attend therapy, because we do offer therapy as well in our facility, and we do co-occurring mental health treatment. So I need to see some accountability on your end, but you are not going to be kicked out of the program. We're going to work on this. Even if they relapse on fentanyl, I tell them, okay, hey, where are we at with your withdrawal symptoms? Yes, depending on the severity, we may need to do a short-term detox, but you're going to step back down to MAT. And if there's any suspicion of diversion, okay, let's maybe consider an injectable version, but I will never say no to anyone. There will always be an option, whether it's going to be a higher level of care, whether it's a different formulation of the medication. But again, we are trying our best to save lives. So if we punish the patients for relapsing, which is in reality a very possible thing in addiction, then they're not going to be able to succeed in their recovery. So we need to show them that we are their ally and that we are working with them and not against them.
And I think a lot of this comes down to, again, education and communication. I oftentimes end up fighting a fight of someone else's started battle, and people will come in on numerous things that, are contraindicated, and it's kind of a, risk versus benefit situation. Do we continue this, which will kill them first? Is that the approach we take? Or, is there risk of them taking this plus this more so than if they didn't have this on board? And that has to be a discussion. And there's a lot of my discussion with my folks is just because you can doesn't mean you should. Some of these folks are prescribed an opiate, a benzo, and a stimulant, and they come to us and say, I don't feel good. Well, no shit. Excuse me. Yes. We're not resolving the underlying. And I think that's where this polypharmacy and all of these other issues come in, is that we're not getting to the root cause of these things. We're trying to gloss it over. We're trying to instant gratification, give them a fix that, we can't Band-Aid this kind of stuff. This is an epidemic for a reason. And if we continue to approach it where we gloss over these situations, when someone comes to me and they're on, I have plenty of people on long-acting injectable buprenorphine. They come to me and they're alcohol benzo positive, there's going to be questions. Stimulants, there's going to be questions, less because, it's less likely to kill, but, there's cardiac implications then. So none of these should be taken lightly, but withdrawing treatment on someone, that's like saying, oh, you have a depressed episode, you don't get your Effexor. That's absurd. We can't yank treatment from folks that are struggling as it is without, doing more harm.
And I know we're ending, but since it's a policy question, I just had a thought that I don't want to tell you because someone might hold me accountable to it. I have not done this, but I just had a thought. As a policymaker, as a guy who reviews policies, we do policy reviews when we got our JCO or Joint Commission, or we've got our CARF, or are we in compliance? I wonder what would happen if we did a policy review and their question was, is this policy written for us or for the patient? And if it should be both always, but I wonder, and I think I actually might take that on as a project. I've never done that, but look through every one of our policies and say, is this for me or is this for the patient? And if it's just for me and it's not in the interest of the patient, I think I need to change
what we're doing.
Yep.
Yeah. Thank all three very much. I think we've had a great conversation in all of our panels today. So can we give this group again a large round of applause? All right, I'm going to ask them, they can step down, but we do have just a general question and answer. I know you've heard a lot of information today, a lot of different resources, and as Taylor said earlier, a lot of them have shared their information with you, so they're happy to continue this conversation. Dr. Delaney, and I'm sure the other panelists would be more than happy to share what they're doing in their facilities and in their organization. I mean, if they have a great program and it's working and you think something like that could work for you, we're here. As I think they've all said, they're here to help you. They want to help you grow your program. How can we help more people, and how can we stop the dying? So we've all been affected in one way or another by this crazy opioid epidemic, and how can we improve our work in what we do on a daily basis? And everyone that's here is very passionate, or you wouldn't be here today. So do we have any general questions related to the topic of medication first or senior substance use disorder, or even a project or a comment that you'd like to share about what you're doing in your area? Anybody have anything they'd like to share before we end the day? Okay. One of the things on your table is that we do have the QR code for today's evaluation. If you can please just take a few minutes for that to tell me what was good, what was bad. I take it all. I'll look at all those. That'd be me. So just if you agree to fill that out for me, I would greatly appreciate it. I appreciate your coming. I know there was a lot of last minutes with this, not knowing, who was going to be here, what was going to be happening. But I appreciate you taking the opportunity and chance to come here today and to hear the, I think, wonderful speakers that we've had today as panelists, and Dr. Delaney with his keynote. Take him up on it. Dr. Delaney wants to help you, okay? He more than willing wants to help you guys. So take him up on that. Again, we will have a recording of this placed on the FATA website, fata.org. I also will download Dr. Delaney's presentation. It will also be there. Give me 3 to 4 weeks, y'all, to pull down the video and all of that and get that on there for you. I think most of you have my contact information for when you registered. Again, it's Diana@FloridaBHA.org. If you're interested in having one of our peer prescriber mentors come to your organization, they're more than willing to help. They'll do it in person. They'll do it over Zoom. We've got a variety of things related. We've got a great science of addiction that talks about how it's a disease and the treatment and why it works with the medications. We've done pregnancy. We've done baby boomer. We've done co-occurring disorders. We've got a variety of talented physicians from the ED to private practice that are more than willing to help you improve your practice coming related to the medications. So again, I thank you for taking the time today to come and hear about this important issue and sharing and hearing what those our individuals had to share today. And I think Dr. Stavros wants to say one more thing.
Here. That. Yeah. Yep. We're here. Just contact me. I've been working with some different coalitions and some things around the state with mental health that are more than happy to find out that this service is provided to you all for free. There is no cost for our experts to come and share their knowledge with you. Just like this event was free today, that training is free for you all to access related to the opioid crisis. So feel free to reach out. We got busy after conference last week. I know we will again for you all, but feel free to reach out. Look forward to seeing you again soon. And I appreciate you all coming and participating. We had great participation today, and we love that because that makes the time go by, and hopefully you gained some great knowledge today. So thank you all again, and be safe traveling back.